Dr. Murphy is one of the 2 inpatient chief medical residents. It's been a delight for me to work with him this year. He grew up in Spokane, Washington, home of the Bloomfest run and 3-on-3, sorry, the Hoop Fest, 3-on-3 Hoop Fest and the Bloomfield run, which Bloomsday. All right, we're getting closer and closer. Bloomsday.
A true California.
I think at 12, the boat's going down. I can see the Facebook thumb going like this right now. All right, but this generation's too young for Facebook, so it's Instagram and Snapchat that's happening. At any rate, Ryan is a wonderful athlete, enjoys that a great deal. He's got a wonderful self-deprecating sense of humor. He describes himself as the least accomplished of his 3 siblings, but he's quite accomplished. He won 2 awards in middle school for poetry, although he claims that A, he has stopped writing poetry and that he's not going to give grand rounds in epic verse. But he is known for his years as a child and as a young adult doing entire conversations with quotes based on TV shows and movies. And he did threaten to do grand rounds in that format, so we'll see how that goes. Both Ryan and I exchanged stories about phlebotomy experiences. And Ryan related this experience where, as a high school student, he was clear that he was going to go into medical school. And he accompanied his girlfriend, ex-girlfriend now, to give a blood donation. And she asked for moral support, asked him to hold her hand while she did this. So she was lying there getting prepared to donate a pint of blood, and the nurse looked over and saw Ryan trembling and nervous, sweaty, pale, and she looked at him and said, "Perhaps you should sit down." And Dr. Murphy, already in the Dr. Murphy mode, said confidently, no, I'm going to be a doctor, I'll be just fine. And about 30 seconds later, he passed out, toppled over his girlfriend, and recovered 10 minutes later and had to drink orange juice. His girlfriend was fine. Many of you are aware of the controversy in the Constitution with the Second Amendment. It's the comma controversy. And the comma controversy relates to whether or not men have the right to bear arms in a militia or they have the right to bear arms, period. And you say, why do I raise this? Well, Dr. Murphy was a major in biochemistry at the University of Washington and a GPA of 3.95, which suggests that there was some comma error somewhere, because as far as I can tell, he got all A's, but somebody made a mistake and put a dash after one of the A's. But he graduated with highest honors here at the University of Washington and then matriculated here for medical school and did his residency here. In medical school, he worked with Dr. Van Voorhis over there, working on small molecules related to tropical diseases, and published 6 papers, one of which he first authored, and one of the papers was in JCI. That's a pretty good resume for somebody who had yet not made it to residency. In residency, he's been working with Dr. Hallstrand on another project related to asthma, and it's going to rock your world a little bit. Those of you who learned about asthma in the 1980s and 90s, as I did, Dr. Murphy is going to present a model of asthma that's quite different than the model that I learned about. His work is very interesting. He spends nights and weekends doing his lab work. He spent the first 6 months regaling me with stories of how he did test after test after test and got negative data and failed, and thought he was actually going to get nothing. And finally, in about February, right before the deadline was due for, I think it was ATS, he had a positive result and managed to produce an abstract that showed a positive finding. He's just a wonderful man. He's going to be a great scientist. He is a great scientist. So I'd like you to welcome Dr. Ryan Murphy and his presentation, Back to the Basics, Time to Redefine Asthma.
Thank you, Brad.
Oh, wait, before we get started, you can put that down because I didn't want you to get light.
You got some OJ?
So I got some sparkling,
wonderful.
Some sparkling apple juice for you.
That is good. Starting to feel a little pale and tremulous as it is. Give that away. Well, thank you very much, Dr. Anwal, for that wonderful introduction. And also thank you, Dr. Bremner, for this wonderful opportunity to present at Grand Rounds. Today I want to talk about asthma, and I think this is a disease that's entering a very exciting new era, and I want to share some of that excitement with you today. I don't have anything to disclose related to asthma, but I do want to make a quick little side journey that hopefully won't derail us too much. In prior iterations of chief resident introductions, Dr. Anawalt has usually come armed to the teeth with compromising photos of us from our childhood. And in preparation for this, I had my mom actually dig through the war chest of family photos from the Murphy past, and she came up with a bunch that were great. And I go, gosh, some of these are more benign and we'll submit those, but don't release the other ones without prior authorization. And I came across one and I figured, gosh, if Dr. Anawalt's not going to use it in his introduction, I should at least tell it because the story's probably too good. When I was 5 years old, for an entire year, and I don't know how this happened, I wore black sweats and a black turtleneck every day, almost every day. And understandably, family members and family friends were concerned. They go, Marchand, what is wrong with your son? Is he depressed? What is going on? He's a depressed 5-year-old. And she was very confidently said back to them exactly why I was wearing black all the time. And the reason was simple. I was convinced I was Batman. For an entire year, I thought I was Batman. And I have to say that luckily died away after age 6. And it didn't happen when I went to kindergarten and was out in the world a little bit more. I'm a little disappointed that my career ventures have drifted off this track toward Batman, but medicine has been a reasonable fill-in. And so to bring us back on track, I want to, in the tradition of grand rounds, focus on the case of 3 separate patients. They're all going to have the same clinical history, but they're going to have the same diagnostic testing and on the same medication regimen. But I hope by the end of the talk, you're going to agree with me that each of these patients is going to require markedly different management strategies individually targeted to their case. And so the clinical history is these are all 40-year-old women. They have a history of variable and recurring dyspnea, wheezing, cough, and chest tightness. They're using the rescue inhaler daily. They've been to the emergency department several times and even hospitalized twice in the last year. You review their prior diagnostic testing and you find that they've had pulmonary function testing performed. It demonstrates reversible obstruction on spirometry, but normal lung volumes and normal diffusion capacity. Their medication regimen, for which each of these patients reports 100% adherence, includes a rescue inhaler with a short-acting beta agonist and a controller regimen of a high-dose inhaled corticosteroid, a leukotriene receptor antagonist, a long-acting beta agonist, and their disease has even become so severe that now they're being managed on an oral corticosteroid, prednisone 5 milligrams daily. And the first question, what's the diagnosis for these patients? And I think that that's actually an easier question to answer. This patient has reversible obstruction on spirometry, consistent with the diagnosis of asthma. But their disease is quite severe and requiring a very aggressive medication regimen in order to control the disease. And I would argue that if you're hospitalized twice in the last year, you don't have controlled disease. So I would define this patient as severe uncontrolled asthma. And I think that's an easier diagnosis to make. The next question, though, of what's the next step in management, I think is quite a bit more challenging. And so where can we turn for help in making this decision? And as I would tell anybody, let's take a look at the guidelines. What do the guidelines have to tell us? And so this is a figure that is very well known to me from my time in medical school. It was published in 2007, the stepwise approach to managing asthma. And our patient is already here at the far end of the ladder. They have step 6 disease, and they're already on this preferred medication regimen of a high-dose inhaled corticosteroid, a long-acting beta agonist, and an oral corticosteroid. And it says here in very small print, consider omalizumab if the patient has allergies. Interesting. What is omalizumab? Should all patients receive omalizumab? This actually gets a little more complicated with the modern stepwise approach. These are the guidelines from 2017. And this patient no longer has step 6 disease, but instead step 5. And it says when we get to this situation, we're supposed to refer for add-on therapy and to consider tiotropium, which is a long-acting muscarinic antagonist, an anti-IgE-based therapy, or an anti-IL-5 therapy. And all of a sudden, this opens up a lot of questions. What are these new agents targeting IgE and IL-5, and how do they function in asthma? And more importantly, which patients should receive them? Is it all patients or a small subset? And how we're going to make that determination on who should receive what? And so I think this actually requires us to take a step back and review the basic science behind asthma and understand some of the pathobiology. And it's laid out here in this review article. This is a wonderful figure, and you can see it's quite straightforward. Allergens, viruses, and particles, particulates stimulate the airway epithelium to produce this inflammatory cascade, which results in upregulation of the innate and adaptive immune system. And it triggers GATA3 stimulation, Oh, my video's not working. Well, we'll have to go without the video. So this, does anybody know who this is, by the way? Yeah, so this is Vince Lombardi. He's potentially the most famous coach in any sport, but he's a little bit of a giveaway here. He was the head coach for the Green Bay Packers in the 50s and 60s. And as another short aside, my brother and I and my dad, growing up, we used to watch this VHS tape called Super Sunday, and it had like the highlights of every Super Bowl from like the early 1960s, Super Bowl I, even into the late 90s. And they had all these great cut-ins to the sidelines of these old coaches making these ridiculous comments. And this one has always stuck with me. And I think it's particularly relevant to this talk because it's a reasonable thing. This is complicated. What is going on with asthma, and how are we going to use this information to dictate therapy? And what I would tell Vince Lombardi and really anybody who asked, why do I need to understand this? The reason is because we have new targeted agents, monoclonal antibodies, that can be applied and improve the lives of patients who have asthma. And it's only by understanding just a small amount of this immunology that we can accurately apply this therapy to the correct patient population. And my hope is in the next 40 minutes or so that I'm going to convince you that these agents are important, should be utilized, but only for a particular subset of patients. And so we started out at the bedside, and we're going to come back to that at the end of the talk, but I think we need to start with our current understanding, or up until recent current understanding of asthma, review some of the basics and how asthma is classified, and then understand how this dictates the current management. And I think what we're going to find is that these patients, this definition has some limitations. From there, I want to go actually back to the bench to talk about our most recent updated definition of asthma and how this is going to help us increase our specificity of how we define the disease, and that's going to help us in applying targeted therapy. And before we get to our patient cases at the end, I actually do want to talk about some research that I've been very fortunate to be involved with, and I hope will tie in quite well. And then again, closing with patient cases where I hope we can apply some of what we've learned. So the current status of asthma is that it's exceptionally common, and I would argue that it probably has underappreciated severity. Approximately 20 million adults, or 1 in 12 adults in the United States, have a diagnosis of asthma. This is based on the CDC's National Health Interview Survey. And it's estimated that 20% of these patients, 1 in 5 or 4 million Americans, have uncontrolled moderate to severe disease. And not surprisingly, these patients had higher rates of exacerbations, they have increased levels of morbidity, and they're at a greater expense to the healthcare system. I would also argue, and I think most pulmonologists and primary care providers would argue, asthma is difficult to diagnose, even for physicians. And although I'm going to play devil's advocate here just for a second and review one study that was done in Canada that I found fascinating, they took a cohort of patients, 700 of them, who had a physician diagnosis of asthma within the last 5 years and reviewed their charts to see, does this patient really have asthma? And 50%, half of the patients, never got a diagnostic study to actually diagnose asthma. They took that whole panel again and retested them very aggressively over the course of the year and found that 33%, a third of these patients, had no evidence of asthma. That is an amazing rate of misdiagnosis, mostly because we're not ordering a diagnostic study to find it. And so one of my pleas today is to please, please, please obtain diagnostic testing to confirm the diagnosis. Asthma is also expensive, and this is an estimate trying to be a comprehensive assessment of all considerations contributing to the cost of asthma, including hospitalizations, medication costs, absenteeism from missed days of work, mortality. And it's estimated that asthma could cost up to $82 billion to the United States per year in 2015 dollars. And that is actually a kind of a shocking number. It's hard to find clear corollary studies between other chronic diseases, but it's not dissimilar from numbers we've seen for hypertension or diabetes. And again, not surprisingly, patients who have severe uncontrolled disease are much more likely to be of greater cost. And that also makes sense. They're more likely to be in the emergency department. They're more likely to be on more aggressive inhaler regimens that are also expensive. Asthma is also exceptionally challenging to treat. And this is worth a talk in of itself, and I don't want to minimize this point. Even if you have the correct diagnosis, managing the disease can be quite challenging. There's a range of comorbid illnesses that co-occur with asthma and can mimic the symptoms of asthma or exacerbate them. And those things are gastroesophageal reflux disease, chronic rhinosinusitis, vocal cord dysfunction, and they're challenging to interpret what symptoms are due to asthma and which are not. The disease also is challenging because it's managed with inhaler therapy. Inhaler therapy is challenging and complicated for patients to use and requires a lot of advanced teaching. It requires daily adherence, which we know patients don't always adhere to the medications we prescribe. And the inhalers are also expensive. And beyond all of that, more taking a look at the socioeconomic context, asthma disproportionately affects patients in lower socioeconomic classes. And I don't want to minimize this point. The focus of my talk is going to be on the definition of asthma, but this is an important point in managing the disease. So let's talk about the old definition of asthma. And this is the definition from around 2007. It had been really well defined that asthma was a disease of inflammation in the airways. And that contributed to increased airway hyperresponsiveness, and you can think of that as an exaggerated bronchoconstrictor response in the airways. And also, the inflammation contributed to airway obstruction. And this is in the form of mucus that is formed and can plug the airway, and it plays back and forth with airway hyperresponsiveness and reversible obstruction to cause the clinical symptomatology that we associate with asthma. This is a figure that is purposely with text that is very small, but I think something that pulmonologists and primary care providers will recognize on how to grade the severity of asthma. This isn't necessarily a confusing idea, but it is cumbersome to remember, and I feel like I would always look it up if I was assessing the severity of patients, remembering how often they're using their inhalers at night and such. And I think that's actually not the point of this slide. The point of this slide is the more frequently that you're using your rescue inhaler, or the more frequently you're having symptoms, the more severe your disease. And the more severe your disease, the more aggressive treatment you require. And so what are we going to do in terms of therapy? Well, you assess the severity, and then you assess a grade to that severity, and then apply that to the stepwise ladder in terms of management. And if asthma is a disease of inflammation in the airways, it makes sense to start with an anti-inflammatory agent. Starting any patient who has mild persistent asthma should be on a low-dose inhaled corticosteroid. But what do we do when the disease gets worse, it advances, or patients have more severe disease, and we ratchet up to step 5? It appears that inhaled corticosteroids are not effective in controlling the inflammation in the airways for some of these patients. And so I think if we're going to understand that potentially patients are going to need additional agents to control inflammation in the airways, we have to understand how anti-IgE and anti-IL-5 based therapy work. And so I think this is really a central question that requires being updated. What is actually driving inflammation in the airways? Inflammation itself is a very nonspecific term. And I want to really, really harp on that. For our rheumatology colleagues, they would argue multiple different rheumatologic illnesses have discrete mechanistic pathways that trigger the inflammatory cascade. And asthma really is no different. And just as in rheumatology, where there are different pharmacologic agents for different clinical conditions, asthma should be the same thing. There are a lot of things that can cause inflammation in the airways. And so this is the one point that I want to stress. We need to spend some time thinking about the molecular mechanisms that are underlying inflammation in the airways. And the reason this is important is going to help us understand how do you apply these targeted therapies. And so I want to move forward now to where we're going now, or what's the current state of the disease in our understanding of defining it. And I would say that a very novel discovery occurred in the mid-2000s, the discovery of a large subset of patients who had asthma had a particular inflammatory subphenotype. Some of them had elevations in a type of inflammation called type 2 inflammation. And there was about 50% of patients who had asthma fell into this type 2 inflammation category. And then there was another 50% that fall away from that. And why am I talking to you about type 2 inflammation? It sounds kind of generic in some ways, but it's actually quite a specific term. And the reason that I'm talking about it, it's important to recognize these patients because these are the patients that are going to respond to targeted therapy. And so the question is now, how are we going to identify these patients and apply correct therapy to them? And for those, and my hope is not to explain all of asthma immunology today. I think that would be quite a grand aspiration today and would require a lot more reading on my part. But I think one thing that I would want people to take away from this is the basic immunology that I think we can learn together and accurately apply these agents. And for those who have seen the show Curb Your Enthusiasm or Seinfeld, you would know who Larry David is. He is the creator of Seinfeld, for those who don't know. But even if you don't know who he is, I think you would appreciate his approach to complex topics. He enjoys simple explanations. So please start. Oh, it won't happen. That's okay. This is a scene where Larry David is ordering coffee from Starbucks, and he orders a cafe latte, and he goes, gosh, this is wonderful. What's in this? What's a cafe latte? And the barista is explaining what a cafe latte is, and he goes, so it's milk and coffee? Milk and coffee, that's it? That's great. Milk and coffee, what a drink. This is so wonderful. And he's quite shocked and amazed that it's a very simple ingredient that creates a cafe latte. And there's less mystique behind a cafe latte than you would think. And so my hope is to leave you with a similar level of excitement and understanding. And the key ingredients, I would say, just as milk and coffee are the key ingredients to a cafe latte, type 2 inflammation has several key ingredients. And these are immunoglobulin E. This is a molecule that we're all familiar with. It's responsible for binding to the high affinity IgE receptor on multiple cell types, but we think of it mostly as binding to mast cells and promoting degranulation. And the mast cells release these inflammatory signals that promote inflammation in the airways. IL-4, IL-5, and IL-13 are all cytokines. IL-4 is a cytokine that's responsible for class switching in B cells. B cells normally produce IgG, but when exposed to IL-4, they switch to start producing immunoglobulin E and precipitating this cascade. IL-5 is an agent that's mostly responsible for all stages of development of eosinophil function. We know that eosinophils are very important in asthma, and IL-5 is important for recruiting eosinophils to the airway and promoting their development. IL-13 is a little bit of a catch-all. It does several things. It promotes class switching in B cells from IgG to IgE. It also recruits, although indirectly, eosinophils into the airway. And it's also responsible for a lot of the mucus production that we see in the airway in asthma. And so what I would say, again, this is more straightforward. This is the milk and coffee of the cafe latte that is type 2 inflammation. And even moving this just a step further, amongst those with type 2 inflammation, there are two clinical subgroups, those with allergic disease and those with eosinophil predominant disease. And what I'm going to stress is these patients are going to have unique clinical presentations, and they're going to have very specific diagnostic testing, which is simple testing that we can all do to identify which patients are which. And we'll see in a second why that's important. But even taking a broader step back, why should we care about type 2 inflammation? Why does recognizing this phenotype matter? And what I would say is this is very, very common. 50% of the patients with mild to moderate severity asthma have evidence of type 2 inflammation in their airways. And this only increases as the disease becomes more severe. Those with moderate to severe disease, 2/3 of them have type 2 inflammation present in the airway. And even more important than this, they often have persistent type 2 inflammation despite our gold standard therapy of inhaled corticosteroids. Half of patients who have type 2 inflammation don't respond to inhaled corticosteroids and have persistent inflammation that's driving their symptoms. But I think the biggest point that I want to hammer home about type 2 inflammation is that we can identify this. Generalists, specialists, subspecialists, all of us can identify these patients with type 2 inflammation based on clinical history and some basic laboratory testing. And so in terms of unique clinical presentations, I'm going to split this in between allergic subtype of type 2 inflammation, eosinophil predominant subtype, and those who have non-type 2 inflammation. Those with allergic disease tend to have onset of their asthma symptoms in childhood. They're more likely to be atopic and have eczema. They're also more likely to have allergic rhinitis. Those with eosinophil predominant disease are a markedly different group. They have onset of disease as adults. They never previously had asthma symptoms as a child. They have very frequent exacerbations that require corticosteroids. And they're more likely also to develop nasal polyps and chronic rhinosinusitis. And so when thinking about these two different phenotypes, for allergic disease, I want to hammer home this picture to you. A sneezing child with atopic disease is the allergic subgroup of type 2 inflammation. Those with eosinophil predominant disease are predominantly older. It tends to be more men than women who have this, and they're more likely to have nasal polyps. And we'll come back to these figures to reorient us later. Those with non-type 2 inflammation are a little bit more of a grab bag. They're lacking a lot of the basic characteristics or classic characteristics we would assign with those with type 2 inflammation. So all of that history is negative. They're more likely to have a history of smoking. They're more likely to be obese. And they're also more likely to have a poor response to inhaled corticosteroids, which I'll talk about briefly later. In terms of unique biomarkers, When I hear biomarker, I think, gosh, this new exciting laboratories test or autoantibody that we're going to be able to order in Epic and try to interpret. That's actually not the case for the asthma. The testing that's best validated in terms of predicting which subgroup patients fall into is allergen scratch testing, serum total IgE, and total blood eosinophil level. And those who have allergic predominant phenotype, they have positive allergen scratch testing, that makes sense, high total immunoglobulin E levels, and they have low blood eosinophil levels. Compare that to those who have eosinophil predominant disease. Again, it makes sense. They should have a negative allergen scratch testing, low total IgE in their blood, and high blood eosinophils. And I will say that there is quite a bit of overlap between these two groups. Allergic disease and eosinophil predominant disease can overlap. And so sometimes patients can have high total IgE and high blood eosinophils, or can be pan-positive for all three of these markers. Those with non-type 2 inflammation are lacking a lot of these same testing, negative scratch testing, low total IgE, low blood eosinophil levels. And we actually don't have a specific blood test or biomarker that we can associate with non-type 2 inflammation. And I'm going to talk about that later. And so we do have tools that we can use to recognize these patients. And the reason it's important to recognize them, as I've stressed before, these patients are responsive to these new targeted agents. And we're going to briefly go through them. Allergic predominant type 2 inflammation, again, childhood onset of disease, more likely to have allergic rhinitis and eczema. They respond to anti-IgE based therapy. Omalizumab is an FDA-approved drug and has been approved for quite some time for management of moderate to severe persistent allergic asthma. Patients with eosinophil predominant disease, again, older patients who are more likely to have nasal polyps and chronic rhinosinusitis, they benefit from targeted therapy against eosinophils, and this is anti-IL-5 based therapy. And we have 3 drugs that are FDA approved for treatment of this, those that are monoclonal antibodies against the cytokine itself, and that's mepolizumab and reslizumab, and then one that's targeted against the IL-5 receptor alpha, which is predominantly expressed on the surface of only eosinophils, and benralizumab is the agent for this. A new and exciting drug that very recently had a phase 3 trial complete and was published in the New England Journal of Medicine looked at a drug called dupilumab. This drug has a unique mechanism of action that it binds the IL-4 receptor alpha subunit. And this is important because that particular receptor subunit is responsible for binding both IL-4 and IL-13, and so can block the signaling from both cytokines, or at least part of the signaling. And I do label it here. It appears based on the color scheme that this should really be targeted towards allergic predominant asthma, but I would say it actually probably belongs better here in eosinophil predominant asthma, mostly because this is the subphenotype that the clinical trials were tested towards. So we don't know about its work in allergic subtype of asthma. All of these agents are proven to reduce exacerbation frequency, reduce asthma symptom scores, and improve quality of life and improve lung function in patients with moderate to severe asthma. But how do we apply it? How are we going to apply this drug to these patients? And what happens when we give the drug to everyone? This is a study that was published in 2007, the initial study of mepolizumab, an anti-IL-5 based therapy. And they recruited patients in a randomized controlled trial, all patients with moderate to severe asthma, with the idea that taking all patients who have inflammation in the airways and not subgrouping these different patients into the right subphenotype. And what they found is the drug was very effective in suppressing the levels of blood eosinophils and sputum eosinophils, which is exactly the biochemical mechanism of action of the drug. But they found there was no difference in asthma symptoms or the frequency at which patients had exacerbations. And so it appeared the early trial was a fail for mepolizumab, and this was not going to be a drug that was effective. 2 years later, a repeat study was performed with the new approach to do targeted therapy for a selected group of patients. And we're going to find that this does work. So they recruited patients with severe eosinophil predominant asthma, again, older patients with nasal polyps and chronic rhinosinusitis. And they ran a randomized control trial with mepolizumab versus placebo. And on the y-axis here, you'll see is the number of exacerbations, and this is the time in months, and they studied these patients for a year. And they found there was a marked reduction in exacerbation frequency in patients who received mepolizumab compared to placebo. And so mepolizumab does decrease asthma symptoms and exacerbation frequency for the right patient population. And beyond this, the current FDA status of all of these drugs are add-on maintenance therapy, addition to our background inhaler regimens. But I think there's some hope that these may become replacement therapy rather than just add-ons. And let's review some of the data for that. This was an interesting trial looking at patients who had such severe eosinophil predominant asthma that they were requiring oral corticosteroids to manage their disease. And what they wondered is, if we give these patients mepolizumab, can we turn back the dose of prednisone that these patients require and still maintain asthma control? And so on the y-axis here is the percent change in baseline of the corticosteroid dose from the start of the trial. And they tested these patients over the course of 12 weeks with either a placebo or the drug mepolizumab. And they found that they were able to successfully wean patients down and reduce their oral corticosteroid burden. And so this is exciting. Potentially, this can replace oral corticosteroids in these patients. Another trial, again, that was recently published with the new agent, dupilumab, looked at patients again with eosinophil predominant asthma, and they had an interesting structure to their trial. On this axis here is the percent of patients who experienced an exacerbation, and this is the time and course of weeks. And so they studied these patients over 12 weeks. They took patients who required a long-acting beta agonist and an inhaled corticosteroid to manage their disease, and then they slowly peeled back therapy over time. So initially they were on their baseline inhaler regimen. They discontinued the long-acting beta agonist, followed by the inhaled corticosteroid, and for the last few weeks of the trial, they were either on placebo or the study drug dupilumab, and these patients retained marked asthma control. There was an 87% reduction in the number of exacerbations in the placebo or in the dupilumab group versus placebo. That's exciting. Patients were on no inhaler therapy and only the study drug and managed to maintain asthma control. And so I think this is exciting. It's fun to have new effective therapies for patients who have a difficult to treat disease. But I still think this actually poses more questions even rather than answers, actually provides way more questions. And central to them, why do patients who have, what's going on with patients who have non-type 2 inflammation? You've seen me spend all my time talking about patients who have type 2 predominant inflammation. What about the other 50% of patients out there? And this is an area of active research. There's some thought that these patients, a large subset of them, have neutrophil predominant disease, and that makes sense. Neutrophils are not particularly responsive to steroids. There's some other thought that there's Th17 and interferon gamma mediated inflammation. There's even some consideration there may be some autoimmune mechanisms leading to airway inflammation in these patients. But I think one of my focuses is, and one of my central questions are, what are the factors that dictate the response to these targeted therapies? And what I didn't show is there are some patients who have type 2 inflammation who have been appropriately selected. They have these biomarkers, they have a classic clinical history, but they do not respond to therapy. What is going on in those patients? And in the opposite arm, why do some patients who don't have type 2 inflammation, they don't meet any of the criteria to be enrolled in any of these new trials or receive this drug, some of them get better with these monoclonal antibodies? Why is that? And I think the way that we're going to be able to understand that, or at least start to understand it, is to increase our understanding of what are the key players that contribute to inflammation in the airways. And so I want to transition the next 10 minutes or so of the talk to discuss what is driving inflammation in the airways and correlate that with a little bit of the research I've been very fortunate to be involved with. It was really long known that mast cells and eosinophils were very much so downstream mediators. They were these effector cells that when stimulated by these type 2 cytokines, they would release a lot of inflammatory small molecules and continue persistent inflammation in the airways. But they weren't thought to be key drivers of the disease. And so what we need to do is actually look further upstream from these cytokines. And one of the easiest questions are, what cells actually make these things? And in the late 90s, there was a cell type called a type 2 helper T cell that was initially discovered, and it was found to be able to secrete these type 2 cytokines, and for a long time it was thought to be the only cell that was making these cytokines and thought to be a central player in asthma. More recently, in the last decade or so, a novel cell type that I actually had never heard of previously prior to entering research in asthma, lymphoid cell, and more specifically a type 2 innate lymphoid cell. They were actually found to secrete markedly higher levels of type 2 cytokines in comparison with these CD4 T cells. And so for a long time, they were thought to be the predominant cell type responsible for driving asthma. But are there really only two cells? And actually, even more than that, which of the cell types is actually most responsible for this persistent secretion of type 2 cytokines in the airway? And so one cell type that has been of interest is actually the mast cell. Potentially, it doesn't just lie downstream of these type 2 cytokines. Potentially, it's further upstream and is important for actually making these cytokines. So I have some research time, a year and a half to 2 years, trying to answer the question, are mast cells capable of producing type 2 cytokines? And if so, what activates them to do this? And in order to answer these questions, I actually need to push you even further upstream. It's been known really for a long time that the airway epithelium is very important in signaling cells in the lung, including in a disease process such as asthma. And this makes complete sense. The airway epithelium is what's exposed to the environment, and they see inhaled allergens and respiratory viruses, which are known to trigger and worsen asthma inflammation. Interestingly, in patients who have asthma, mast cells aren't just floating around down here in the submucosa. They're actually found higher up, actually embedded tightly within the airway epithelium. And so they're in quite close contact with the airway epithelium, which might make for more efficient cell-to-cell communication. And the key signaling molecules that are really important for activating cells to produce type 2 cytokines are these three small molecules called IL-25, IL-33, and TSLP. I'm going to spend most of my time talking about IL-33, but every one of these cytokines has been shown to activate type Th2 CD4 T cells and innate lymphoid cells to produce type 2 cytokines. And the question is now, do these signaling molecules activate mast cells to produce these same cytokines? And the answer is, of course, yes. It wouldn't be as exciting if the answer was no. In this study, we took mast cells from the bone marrow of mice and stimulated them with one of these three agents, IL-33, IL-25, or thymic stromal lymphopoietin, and then measured the expression of a type 2 cytokine gene, IL-13, and then measured over the course of time if there was gene expression. And there's a marked increase in IL-13 gene expression when we expose these cells to IL-33, but interestingly not with IL-25 and TSLP. And we can correlate this with production of the protein. This is the concentration of the IL-13 protein. And again, over time, after stimulation with IL-33, there's a marked increase in IL-13 protein production. And so this is actually very exciting. Mast cells communicate with the airway epithelium to produce IL-13, but only in response to IL-33. And that was actually a novel finding. It was thought that mast cells could produce type 2 cytokines, but it wasn't clear exactly which small molecule mediator from the airway epithelium was responsible. It was thought that IL-25 or TSLP could be responsible for that. But this was really a new idea. Mast cells may be actually essential to asthma pathogenesis. They may not just be downstream effector cells. They may be upstream and responsible for precipitating and driving type 2 inflammation. But the question, of course, now is, how is this process regulated? Are we going to look deeper into mast cells? And the reason that I think it's important to understand how the system is regulated is this is how we identify new drug targets. And one protein group that has been of interest that Dr. Hallstrand and other colleagues in the Center for Lung Biology have been studying is called secreted phospholipase A2 group 10. And that sounds like a mouthful, a lot of words, but I will tell you that actually I think all of us are familiar with this subclass of proteins because they're really important for the initial step in producing leukotrienes and prostaglandins. Well, remember, Singulair montelukast is a leukotriene receptor antagonist. We know leukotrienes promote inflammation in the airways of patients who have asthma, and this protein starts the initial cascade for making these molecules. It cleaves membrane phospholipids to release free fatty acids and lysophospholipid, and this then, through the cyclooxygenase and lipooxygenase pathways, produces leukotrienes and prostaglandins. And this specific protein has been implicated in human models of asthma. Patients who have severe asthma, if you look at the fluid in their airways, they have markedly elevated levels of this protein in comparison to healthy controls. And in mouse models, if you delete this gene, you will find that these mice have impaired type 2 inflammation in their lungs. So this is interesting. This protein may be responsible for manipulating type 2 inflammation. The question is, does it do that in mast cells? And so the next arm of the study was to stimulate two different populations with mast cells with IL-33, a wild type group that has this protein. But if we delete the gene in another subset of mast cells that are now PLA2 group 10 knockout mast cells, and ask ourselves the same question. Do either of these cell types still produce IL-13? And what we find here, this is IL-13 protein production, and this is the time in hours after exposure to the cytokine IL-33. And the black bars here represent wild-type mast cells, and the white bars here represent the knockout mast cells. And what we'll see if we focus on this 24-hour time point, if you knock this gene out, there's a marked reduction in type 2 cytokine production. That is fascinating. Why is it that that happens? That all of a sudden in mast cells, they produce markedly lower levels of a type 2 cytokine with stimulation with IL-33? I'm also interested to the answer to this question, and I've spent a lot of time trying to uncover it. My hope is to come back with something in the literature soon that will hopefully explain this mechanism. But why care about this? Why care about some of this basic science research? And I think it's because mast cells really may be an underappreciated driver of type 2 inflammation. And anti-IgE and anti-IL-5 therapies really don't target this pathway. If we go back to our original figure here, if we target IgE with omalizumab, that's gone. If we target IL-5 with mepolizumab or one of the other agents, we get a reduction in eosinophil levels. This actually leaves a significant amount of the inflammatory cascade still intact. It's unclear how dupilumab, this new IL-4, IL-13 agent, is going to work in this pathway, but I think it's of some interest that if we're only targeting a specific couple cell types, we're actually leaving a lot of the inflammatory cascade intact. And I think understanding how this process is regulated is going to be very important for uncovering new drug targets. And we've already identified that secreted phospholipase A2 group 10 may be a potential drug target. Dr. Bill Henderson and Dr. Mike Gelb and also Dr. Hallstrand have looked at this protein and developed human inhibitors and to see potentially is this a therapeutic target for managing asthma. I will tell you the pharmaceutical companies are quite interested in IL-33. There is a lot of money involved in them purchasing these monoclonal antibodies and are starting some initial testing in asthma. And so now I want to bring us back to the bedside to understand or try to apply what we've learned and try to see which of these therapeutics are going to benefit these three patients. And so this is going to be a very quick aside. One of my pet peeve is the wrong term for it, but if anybody, residents, medical students, attendings who have read my notes, some people would tell me that I think they're wonderful. Other people would say they are just dramatically terrible, and there's way too many dashes and hashes. I like a very clear organization of my notes. And what I wish that consultants would do sometimes is really put their money down and say, my impression is this patient has this disease process, and then under that, write their like paragraph or description of why they think it's that. But I wish we'd put our money down just a little more often. But again, we had this question, sorry, that's a total aside. The recommendation, though, was again a question. We didn't know what we were going to recommend. And I think because actually in the impression there needs to be a subtype. So here we go. My note documentation is intact. And you can see here, there are 3 stars that are here. We are not going to be able to close this epic encounter until we like fill in that this box right here. This is going to be frustrating. So we got to come up with the answer to this. And the subgroup here is we need to identify the molecular phenotype for each of these patients. And we can do this. Let's go back to each of these patients and ask some more clinical history and do some lab testing. Patient 1 had childhood onset of their disease. They have a history of allergic rhinitis and eczema. They have elevated total IgE levels. They have low blood eosinophil levels, and they have positive allergen scratch testing. This patient has type 2 inflammation and an allergic subphenotype, and this patient should be treated with anti-IgE based therapy. The second patient has adult onset of disease. They have severe disease, and they have chronic rhinosinusitis. And their laboratory studies show normal total IgE levels, elevations in their blood eosinophil levels, and negative allergen scratch testing. This patient has type 2 inflammation, but an eosinophil predominant subtype, and they should be managed with anti-IL-5 based therapy. The third patient has adult onset of disease, is a former smoker, and is obese. And their laboratory testing doesn't show elevations in any of these type 2 biomarkers. Normal total IgE, low blood eosinophil levels, and negative allergen scratch testing. This patient has non-type 2 inflammation driving their asthma. And this is a question, again, of active research on what to do for these patients. There's some consideration for giving these patients long-acting muscarinic antagonists with tiotropium. Weight loss is certainly effective for patients who are obese. There's even some consideration for bronchial thermoplasty, and there's some exciting research that's going on in that field. And so I think to close here with some take-home points, what I want you to leave with an understanding is 50% of the patients who have asthma have evidence of type 2 inflammation in their lungs. And our patients who have severe disease are much more likely to have this type of inflammatory cascade present, and they're much less likely to respond to our standard therapies. We have new targeted agents, and they are proven to reduce exacerbations, improve quality of life, and improve lung function, but only if applied to the correct phenotype. And we really need to do a better job of taking more careful clinical history and ordering some very specific testing to identify these patients. And then lastly, that mast cells may be an underappreciated driver of type 2 inflammation. And I think understanding this regulation, how this process is regulated, will uncover new drug targets and is kind of the focus of some exciting research going forward. And so before I pause for questions, I do have some acknowledgments. Of course, a lot of the work that went into this presentation and my research is because of people around me who have been incredibly helpful. And Dr. Teal Hallstrand is chief among them, helping with research. It has been really, truly a pleasure to work in his research laboratory. And I appreciate his patience, and also Dr. James Nolan for his patience in my relearning of how to be a physician scientist. It had been several years since I'd been working with Dr. Van Voorhees and Dr. Dustin Malley doing really organic chemistry. This is a very new adventure for me, and it's been a fun ride so far, and I'm excited to continue it in the future. In the UW Internal Medicine Residency Program, of course, the residents, this makes this job so very fun. There are too many people to thank. My group of chief residents that I am so very fortunate to call myself one of you guys. I really appreciated the suit put on of that. That was great. You truly are an amazing group of people, and I feel so very proud and honored to be among you. And Dr. Annewald, for his tireless effort, one, to improve this presentation, that he had such a great hand in making this presentation, what I hope seemed a good presentation. I guess I shouldn't speak too soon. It's his fault if you don't like it. But he has been really, truly an incredible mentor over this year, and I feel very fortunate to have his mentorship. And then lastly, Dr. Bremner. This is such a wonderful stage that you give the UW inpatient chief residents. We understand that this is not a common thing across the country to allow such junior trainees to present at such a large forum. And so we're so incredibly thankful for this opportunity. And even beyond that, I know the incoming department chair, whoever that may be, will be wonderful. And I'm excited for the next upcoming chief resident class to work with that chair. But I think Dr. McConaughey and I would feel we feel very fortunate to have been able to work with you over the past year. And with that, I will take some questions.